All right. Good morning, everybody. So, as the wilderness guy, I've got an interesting collection of topics that may not seem terribly relevant, but you'll see why they're relevant here in a bit. There's a weird echo coming through. Now it's muted. So the first one's going to be on diving and barotrauma, so environmental emergencies. Diving is, of course, interesting and fun, and I hear there's a reef that is only partially bleached around here that people go diving a bit north, but we probably will see some of these a fair amount. But there's an interesting pathophysiology to diving, specifically to barotrauma, that we need to discuss. And when we start off discussing barotrauma, the first one is barotrauma of descent. Now, often, as I watch the lag, this is great. Often you'll see this chart, and it's in freedom units because you can't find them in metric for some reason. But you'll see these charts that shows this gas bubble volume, and it's 150 and 33 and 25. And that is great for visuospatial representation. It is completely inaccurate. The volume of a bubble that's 50% of the volume of a different bubble is not 50% of the diameter because the way we do math. So what we need to do is gas bubble diameters and not pictographic forms, because bubbles are spheres. And the volume of a sphere is 4/3 pi r cubed. So I'm not going to make us do math today. Just be prepared to show your work when I do. And so if you've got a gas bubble, and it's easier to think about gas in round kind of bubbles because that would be how they are in an ideal environment, which our capillary bed is not how they are. When you go down to 2 atmospheres and you have half the volume, you still only have 79% of the diameter. And I'm not able to draw spheres on here for you, sorry, but this is as close as we can get. And so when you go down to 3 atmospheres, it is 1/3 of the volume, but it's actually 69% of the diameter. And 4 atmospheres, 63% of the diameter. Down to 5 atmospheres, which is at the 40-meter mark. So 1 atmosphere is at sea level, and then every 10 meters you go down, it adds an atmosphere. You're at 58%, and then finally at 6 atmospheres, which is as far as any normal person should dive, really, you're down at 54% diameter. And so when you look at it pictographically, the bubbles are not that size. And so when you think about it, it's not a volume of the bubble issue. It is, because of Poiseuille's law and the speed to the flow is in proportional to the radius to the 4th power, but it's not bubble size. Is not how we need to think about barotrauma. So we'll put a little mark through there. So what it actually is the suction available that causes that barotrauma in barotrauma of descent. So mask barotrauma is when you don't equalize the pressure in that airspace in your mask. If you go down far enough, because the pressure forms, it creates basically a suction. It starts trying to suck your eyeballs out through the front of your head. It also sucks out blood, causes other issues. It can actually cause orbital hemorrhages, make you look really super awesome for the flight home, things like that. Just having a really, really bad day. And that's easily fixed. You just kind of equalize the pressure in your mask by blowing out through your nose. Other air-containing things that have pressure walls that will not change are your sinuses. Certainly, if you aren't able to equalize your sinuses, you'll have a very bad day, especially down as you go. It'll hurt. As you come up, you'll start bleeding out of your nose, and you'll see all these things. You can actually have external auditory canal barotrauma. It usually involves having some type of either Schrumann plug or even a dry suit that seals really well on your ear. Remember that pressure, that suction will cause that air pocket to try to expand or try to compress, and it'll pull your eardrum out and cause some serious pain. Can even rupture your eardrum as we slowly go through the pictures. And then you start getting into the serious ones. So middle ear barotrauma, if you're not able to keep your eustachian tubule, which connects your inner ear to your middle ear to your throat, if that collapses on you, then you can have your TM pull inward. You can also have a really serious rupture. This happens underwater. You get extreme vertigo. You get cold water calorics in the middle ear, which really helps space yourself, orient, and you can be in serious trouble if you get bad vertigo underwater. You can drown because you can't get up.
How much pressure do you need to do that?
So they put in tympanostomy tubes for the dive chamber, and the dive chamber only goes to 1.8 atmospheres on top of normal, and so you can rupture at 10 meters. So 2 atmospheres will pop it if you're not able to get it done. The nice thing about traumatic ruptures is they actually heal pretty well. They don't often need surgery. Infectious ruptures, you know, they have chronic draining fistulas and things like that. But traumatic ones will heal. You just can't die for a couple of weeks, and you won't want to anyway. There are a few equalization techniques, clearly. There's the Valsalva, as epitomized by the great Dizzy Gillespie. He was able to do it a little bit differently than the rest of us. There's Toynbee's, which is basically swallowing with a closed nose. So you just swallow with your nose pinched off. And there's the Fresnel technique, which is honestly, it's essentially moving your jaw back and forth to get your ears to wiggle. The great thing about describing that is every single one of you is doing it right now. And so I can see it happening. I'm not sure why it has that kind of yawn technique, but people do it. And that will help open that eustachian tubule. Because once we get past the middle ear and you start worrying about the inner ear, is when you can have serious kind of long-standing issues. So the inner ear is that, you know, semicircular canals, but things the bones connect to, the oval window and the round window. If you rupture one of those 2 windows, it's not just vertigo, it's completely obliterating vertigo. It's not tinnitus. They describe it as a train roaring through your head because the sound is just so immense because your bones are just rattling and your brain can't figure out what that signal is supposed to be. And so you get this massive ringing in your ears that sounds like a train rolling through your head. You don't want to have that happen. These often can require surgery to repair and can cause permanent sensory hearing loss. There's other squeezes that are interesting. If you ever have the ability to go in a dry suit and then go to 6 atmospheres down, I recommend not doing it because it's cold and dark down there. But if you have an airspace between your skin and the dry suit and the pressure is not equalized, it will try and suck your blood volume out through your skin and cause these interesting little rashes. We also have barotrauma of ascent, which is the opposite. So once you get that air pocket compressed down to a small volume, as you ascend, it'll expand. You can have what's called alternobaric vertigo. So the air pocket in your middle ear can expand and cause some vertigo. You can also get a facial nerve palsy if your 7th cranial nerve is going through that space. The issue with this is just like Bell's palsy. So you want to make sure they're not having arterial gas embolism and having a stroke phenomenon as opposed to just a Bell's palsy. So you want to treat it as such, but that can happen. Or you can have the most annoying sounding one, which is tooth squeeze. So if the pressurized air is able to get into a cavity or pocket in your tooth and then can't escape and you raise, it'll explode your tooth in your mouth, which sounds painful and does not really seem enjoyable. But when we talk about decompression sickness, it's not really barotrauma in the sense of barotrauma. So when we go back to the schematic of diameters and volumes, remember, it's not bubble size. It's actually more like this. So it's little bubbles kind of coalescing into a foam and causing vapor lock in your bloodstream. And that's why it's not a bubble expanding issue. You've got a few different kinds. Depending on who you read, they talk about type 1 and type 2 and type 3. Generally speaking, it's a lot easier to think of the ones that only cause pain. So the musculoskeletal decompression sickness where it affects the joints. For whatever reason, caisson workers, that old-timey picture at the very beginning, affected their lower extremities, which is why they bent over at the waist, whereas actual commercial divers and recreational divers, it's the upper extremities. We don't know why that is. The fluid physics just did not explain themselves very well to us. But that's mostly joint pain. You can also get cutaneous decompression sickness, but when you start getting into this, about 20% of the people who have this have neurologic findings. And so we're not entirely sure. This is different than suit squeeze. It looks very similar, but it's different than suit squeeze. And so we think it's actually a neurologic phenomenon with the cutaneous nerves causing spasm of the arterioles and allowing this kind of exudative skin and causing a peau d'orange of the skin as well. You can get pulmonary decompression sickness. It's called the chokes. And so as you get small air bubbles getting into the pulmonary arterial side, so from the venous side into the arterial side of the pulmonary system, basically small pulmonary emboli, but they're air, you get coughing and spewing and things like that. If you get enough of it in the right side of the heart, you can get a mill-will splash murmur. So if you ever put your stethoscope on somebody on a boat, you're doing something wrong. But if you happen to have it and you hear a splash, 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 splash thing, it's very bad. In that situation, if you can, put them in a feet up kind of right lateral decubitus so that that air bubble is at the very apex of the heart and not being thrown into the pulmonary system is the ideal way of doing it. Once you're at that point, you're pretty bad off. Don't worry. As I mentioned, type 2 or neurologic decompression illness, which 20% of the people with skin changes have, is the more severe form. And these people will often have more permanent sensory loss. So it's probably a more severe type as opposed to a specific kind. So it's probably an aggregate amount. So if you have a small amount of foamy bubble somewhere, it's probably just painful skin conditions. But if you get a large amount, it starts causing neurologic deficits. And we know this because the joint pain usually goes away. Whereas if you have neurologic disease, you usually have symptoms. 50% of people have symptoms even 6 months later. So it's probably more of an ischemic phenomenon just from air bubbles. And then finally, you get pulmonary barotrauma. If you forget to breathe out as you're ascending, your lungs will pop. Probably not through your skin. If you get to that point, that would be pretty severe. Don't hold your breath that hard, but it can cause the most severe form, which, depending on who you read, is listed as a type 3 decompression illness, the arterial gas embolism. Once you get air bubbles into the systemic arterial side, it is no different than any thromboembolic phenomenon. It goes to the bad things. It can cause complete occlusion to an extremity. It can cause stroke symptoms. It can cause other things. The issue is 20% of us to 26% have a patent foraminal valley. And if you get enough of a pressure differential, you can get that shower of foam to go from the right circulation to the left circulation, and you can get this anyway, even without the pulmonary side. The bad thing about arterial gas embolisms is we like to find them on autopsy. I'm not sure why autopsies are CT scanning dead people, but this particular person had a significant amount of air in and around their skull, in their orbits, and even in their eyeballs. So you can move a severe amount of volume, and it's not just the sheer size of it, where they talk about, 100 milliliters will completely kill you. Well, you can have more than that in a lot of spaces, and it can still kill you, right? There's clearly a significant amount of air in all of the vessels in this person's head. And if you have so much air in your heart that it's not visible in X-ray, you are having a bad day. So it's quite a bit of air in that system. And remember, the reason I keep harping on this model is because it's not the diameter. Like I said, it's more like foam physics, aggregate of shaking up a Coke bottle. The fizzy comes out on the top. Because if it were the size of the bubble, then the argument would be when we dive people, we need to dive them back down to 6 atmospheres or more, dive down to 10 atmospheres. I mean, if you make the bubble that much smaller, it'll make everything better, right? It's not really the bubble. We only dive people to about 2.8 atmospheres with dive table 6, which is the common decompression dive. It's the 100% oxygen at 2.8 atmospheres that sucks the nitrogen out. Because when you're breathing air, at least commercial air, you're usually using a 79% nitrogen carrier gas. You get that nitrogen pushed into the tissues, and as you come out, it makes those little microbubbles that foam up. So we denitrogenate them, just like when we put them on oxygen for their pneumothorax, to try and suck the oxygen out or diffuse that gradient to make the amount of air smaller. Often they'll do 2 to 6 of these, depending on how bad they are. But it does work pretty well. It just takes a long time. Because we fly aircraft, we have to have some altitude considerations. But when you think about it, it's not quite as bad as we would say. So sea level, 101.3 kilopascals or 1,000 hectopascals, depending on how you want to do it, is really, even at Everest at 30,000 feet or 6,000 meters, or 8,000 meters, sorry, that's only a third. So the difference between the highest point on Earth and sea level is only a third of the volume, and so that's basically 2 atmospheres down. So 20 meters down is the inverse proportion. If you go from 20 meters to sea level, is the same as going from sea level to 8,800. So air is a lot less dense than water. As you can see it here, like I said, it's about 10% off. The 50% mark is 5,500 meters. Generally, we're not flying that high. So it's not as big of a deal. If you pick somebody up for decompression illness and you're taken to a dive chamber in the aircraft, in a helicopter, you're not going to be flying high enough to worry about it. If you're picking them up in Broken Hill, you have to figure out why they're diving in Broken Hill. And then as you're flying over the mountains, you want a sea level cabin. There is a specific group of crazy people that like to dive at altitude. These people, you do need to consider sea level and make sure that the cabin pressure is good. If you're in a fixed wing, you can't really modulate the air pressure in a rotor wing unless you have a gamma off bag, and you have to put them in that. It's really hard to do stuff when people are in a big inflatable bag. This particular gentleman here, his name is Marcel, set the Guinness record. He dove in what is essentially a collection of meltwater on Aconcagua there. It's 6,600 meters. He had to dig through 3 meters of ice to get into the water. This is his third attempt. The first time there was snow out conditions. The second time, 2 of the team members had to leave because of frostbite. But by God, he got it the third time, so he could set his stupid record. And be completely untreatable if he had decompression illness. Because if you're that high up, your bubbles are gonna foam everywhere. So like I said, if you're going over high altitudes, you want a sea level cabin. In our rotor wings, it's not as big of a deal. You're taking them to a dive chamber, which is convenient. They're in it for a long time, so make sure and take some reading material. Conveniently, he's reading Diver magazine because that's why he's in there. But honestly, most dive chambers are slightly larger, and they're more for wound care. So you gotta know where to take people so you can get the correct treatment for decompression illness. In the acute phase, if you've got somebody that has concerns for any decompression sickness or arterial gas embolism, the only treatment we can do is 100% oxygen. So give them that. You may need to secure their airway to give them that 100% because the Hudson mask is not going to quite get as high. And if they're having stroke-like symptoms, you probably want to secure that airway anyway. There's a couple other non-barotrauma diving things that are interesting that we're going to kind of finish on because they're useful for us for information purposes, because we will see some of these too probably. Diving is less of a recreation here, but free diving is what people do. The swimmers and things like that will be out there. Shallow water blackout is a phenomenon where people will hyperventilate to blow down their CO2, and then they'll jump in the water, and they'll use up their oxygen, and then they die. And the reason why that is because in addition to Boyle's law, like we discussed, where P1 equals V1, P1 V1 equals P2 V2, there's Dalton's law, which is the partial pressures of gases is the aggregate of the total pressure. When you blow off your CO2, your brain uses CO2 as a set point, most of us. So if you blow off all your CO2, you're not going to think to breathe. And so if you're normal diving, as you use up your oxygen while you're diving, your CO2 rises, your oxygen goes down, and you feel like you need to breathe, and you go up to the top of the surface like a normal person, and then you start breathing again once you get up to air. If you blow down your CO2, so you start off with a lower amount, once you dive down, you're using up oxygen, and that partial pressure of oxygen goes up because you're diving down. As you go up, that partial pressure of oxygen that you've used starts to go down and is below the point of blackout. And so when you get to around 10 meters from the surface and up, suddenly the partial pressure of oxygen in your bloodstream is less than 10, which is usually the part where you pass out. And so you'll start to get to the surface, and then you just slump because that partial pressure goes away, and you no longer have that driving force to get it across from your lungs into your bloodstream to your brain. And so you'll see people just floating on the surface. The good news is, if you give those people oxygen and rescue breathe for them, they'll usually come back pretty quickly because nothing physiologically is wrong. They haven't blown along or anything like that. The issue is it's very hard on the dive boat to figure out if the person floating in face down in the water is a shallow water blackout or an arterial gas embolism. So you need to, certainly give them 100% oxygen, bag valve mask. If they don't recover quickly, secure their airway so that you can fix their other issue. The other recreational diving issue, when you're breathing a carrier gas that has 79% nitrogen, is you can get nitrogen narcosis. Makes you do dumb things like stick your arm in the mouth of a shark to try and pull a hook out. That one's named Bitey. Nitrogen narcosis is interesting because once you get down to 60 meters, it's the equivalent of having 4 martinis, which probably is not the smartest thing to do when you're diving, especially not when you're diving that far down, because it takes a long time. You can have a lot of stops on the way back up if you're at 60 meters. So again, all of these have to do with physics and partial pressures, but be aware that it's not just the bubbles. There's a lot of things to it. Any other questions or anything?